Hello, everybody. I am Daniel Verdecchia. I am a physical therapist here in Buenos Aires, Argentina. First of all, I would like to thank Dr. Alfahar Mohammad for inviting me to participate in this international course. I will turn off my camera so that you can see the slides better. Okay, here we are. Today I'm going to talk to you about the latest development in gait stabilization exercises. Okay, let's get started. Here you can see a little bit of information about myself. The objectives of this talk are to review the concept of dynamic visual acuity, to describe the DVA evaluation, to review the traditional gait stabilization exercises, and to report the latest progress in this field, incremental and unilateral VOR adaptation. Primary vestibular afferents of the healthy vestibular system typically have resting firing rates between 17 and 100 spikes per second. Imagine two airplanes flying 24 hours a day at 100 meters above the ground. This represents our vestibular system. If both airplanes fly at the same altitude, there will be symmetry. This is interpreted by the central nervous system to mean that the head is not moving. When we turn our head to the right, the airplane on the right goes up, and at the same time, the airplane on the left goes down. This is interpreted by the central nervous system to mean that the head is moving to the right. The angular VOR that generates eye movement in opposite direction and equal magnitude with respect to head displacement in healthy subjects, ensuring clear vision during fast head rotations. Angular head rotation stimulates each canal in varying degrees, and each semicircular canal responds best to motion on its own plane and exhibits a push-pull dynamic with the opposite coplanar canal. Now, imagine that one of the airplanes has problem and loses altitude, so now it's flying at only 50 meters above the ground. This represents unilateral vestibular hyperfunction, or even worse, the airplane crashes to the ground. This represents a complete unilateral vestibular loss. This asymmetry is not well tolerated. When this asymmetry happens suddenly, the patient has vertigo, but when this happens gradually, the patient suffers from dizziness. As you can see in the picture, the patient has a left vestibular hyperfunction. This type of lesion causes two big problems. One of them is oscillopsia and blurred vision. The other is posture and gait imbalance. In this lecture, we are going to focus on the upper arrow. Oscillopsia and blurred vision are generally measured using the dynamic visual acuity test. The major impact of the DVA loss is on bilateral patient. DVA tested while walking on a treadmill is one of the few close to reality functional outcome measures of vestibular function on the vertical plane. This type of evaluation shows that bilateral vestibulopathy patients have greater DVA loss than those who are unilateral. DVA loss has a strong negative impact on the patient's quality of life because it severely limits his activities. For example, driving becomes a problem, and so do reading and watching TV. And all of this makes it more difficult to have a social life, so the patient begins to suffer from feeling of isolation, even without COVID-19. This study highlights the role of covered saccades to improving dynamic visual acuity in bilateral vestibular hyperfunction. Covered saccades occur in 76% of head impulses. Dr. Verdecchia's quantified covered and overs a case in a group of 49 patients who had undergone resection of an acoustic neuroma at least a year before, none of whom had vestibular rehab. They found that the group in which saccades were highly organized had a lower DHI score. Clinical DBA test is an efficient, simple, and non-invasive test that can be routinely used in the clinical setting. It's very important to maintain the same frequency and range of motion for the whole test. We use 2 Hz for the yaw plane and 1.5 Hz for the pitch plane. You can use a metronome to help. In this study, Dr. Dannebaum in Canada found no difference between vision chart type. In this picture, we can see an example of DBA test for unilateral vestibular hyperfunction patient. The line in blue represents the static visual acuity and the line in orange represents the dynamic visual acuity. There are 6 lines of differences between the 2 visual acuity. 3, 4, 5, 6. Don't forget that 2 or more lines of difference is abnormal, and this should be interpreted as a patient who suffers from gaze instability. This person could benefit from gaze stabilization exercises. Computerized dynamic visual acuity test is an interesting way to measure gaze stability, but it's more expensive and not all clinics have it. In fact, we only use this technology to do research at the university where I teach. That's how we evaluate our patients. Now, what do we do? Vestibular rehab is a good option. One of the central principles of the VR is improving gaze stability, and gaze stability exercises are commonly prescribed for this purpose. The second principle is that gaze stability rehabilitation program that should be started very early and actively after the onset of the vestibular pathology. These are 2 of the best known adaptation exercises, and they have already been well explained to you by my colleagues in this course. However, I think we should take another quick look at them so we can be sure we understand everything before we compare and contrast them with the latest advances in this field. In the VR time 1 exercise, the patient focuses his eyes on a stationary target, usually a letter, and rotates the head sinusoidally in either the yaw or pitch plane. In VR time 2, both the head and the target are rotated in equal and opposite directions. For example, as the head rotates to the left, the target is moved by the patient to the right and vice versa in a sinusoidal pattern. In this 2 paradigm, the head is moving from side to side, so in unilateral vestibular loss patients, we are training the normal side too. We will get back to this later. We know that randomized controlled studies have shown that these exercises clearly improve gaze stability in patients with both unilateral and bilateral vestibular hyperfunction. The mechanism to improve gaze stability with exercise is twofold. The gain of the VOR is increased, and compensatory saccade is recruited. In this video, we can see the VOR time 1 in a standing position. Note how the eyes continue to be focused on the target in spite of the fact that the head is moving. We should remember that the target must be clear and well defined. In this exercise, we need more coordination because the head and target move in opposite directions at the same time. The duration of both paradigms is between 1 and 2 minutes. And these two substitution exercises more specific to bilateral vestibular hyperfunction. One of them is called the two targets exercise, and the other is called the imaginary target exercise. We can progress to more difficult levels taking into account duration of the exercise, the velocity, if we use only foveal stimuli or a complex background, the position of the patient, it means lying, sitting, standing, walking, and also the distance between the eyes and the target. This program, which was published in 2010, is an example of how different exercises are combined into one gaze stabilization treatment plan. On this slide, we can see the average treatment times which are necessary to see an improvement in the patient conditions. Based on the latest clinical practice guidelines for vestibular rehab, patients should do these exercises 2-3 times a day and see the physical therapists once a week for re-evaluations and supervisions. However, this is still based on the experts' opinion only. In this video, I would like to show you how we can use the computerized DBA test as treatment. We can use this software for gaze stabilization exercises, and we change the letter size, the background, the head velocity, and the time. In this slide, we can see the training result of the video we just saw. These softwares can give us two types of information, numerical and graphic. This patient performed the VOR time 1 exercise for 30 seconds. The average head velocity was 85 degrees per second, and she correctly identified the orientation of 11 out of 13 optotypes. As I said before, this software is very expensive and consequently is not widely used or easy to find. In gaze stabilization exercises, the subject with vestibular hyperfunction is instructed to keep his eyes focused on a target during head rotation. The exercises are a form of vestibular adaptation and are designed to expose the patient to retinal sleep. Retinal sleep occurs when the image of an object moves out of the fovea of the retina and resulting in visual blurring. Retinal sleep associated with head motion is necessary for VOR adaptations. However, the brain can tolerate some sleep without the subject perceiving it. Therefore, it is important to instruct the subject to ensure the target is clear and not moving or blurring when they rotate their hair. What does the future hold for gaze stabilization exercises? From now on, most of the information I'm going to give you is the result of the work done by two well-known researchers in the vestibular area. These investigators are Dr. Michael Schubert and Dr. Americo Migliacci, and I would like to pay tribute to them and their team for their ability, effort, and dedication. Thank you to them, our knowledge of VOR adaptation has increased greatly. For the time 2 paradigm, The error signal might have been too big for the adaptive process to create lasting modifications, perhaps due to the brain perceiving the stimulus as invalid. This is the first publication about a new way to enhance BUR gain. The author called this incremental velocity error signal, or IVE. In comparison with a conventional constant and big velocity gain demand, the time to paradigm, the incremental paradigm might provide a small enough error signal to make the brain believe that it's valid. In this case, the brain might try to make a more enduring modification. This method successfully improved the BOR gain in patients with unilateral vestibular hyperfunction. In this study, 7 individuals with normal vestibular function and 6 individuals with unilateral vestibular hyperfunction were exposed to the IBE and time to paradigm as a control group, ABR demand tasks. All subjects performed about 300 self-generated head impulses, divided into 10 epochs of 13 head impulses with 30 or 60-second rest period between epochs. For incremental paradigm, the subject was asked to make 30 self-generated head rotation while viewing a rear projected laser that moved with 10% of the head velocity in the opposite directions. During a brief rest period, the target velocity was manually increased by another 10%, now 20% of the head velocity, for an additional 30 head rotations. This incrementing continued until the subject had made approximately 300 self-generated head rotations. The final 30 asking for a 100% gain increase, or time to adaptation, which typically occurred within 15 minutes. In the picture, we can see eye and head velocity and positions showing compensatory saccades occurring only during the incremental training paradigm. The superior curves, A and B, is the incremental paradigm for the first and the final training epochs, and the inferior curves, say C and D, the same training epochs for the time to paradigm. This data suggests that rehabilitation strategies focus on improving ABOR function in patients with unilateral vestibular hyperfunction should use an error signal that is incrementally adjusted based on the individual's present ABOR performance. Migliaccio and Joubert use the same IB training paradigm as described before, but investigated the good effect of targeting an increase in gain towards one side only, and called this side the adapting side, in a group of health controls. The training program was designed so that when head movement were towards the adapting side, the laser targets move in the opposite direction and with increasing gain demand. When moving to the non-adapting side, the laser target disappears, not demanding any gain change. The findings were surprising in that active BOR gains to both adapting and non-adapting sides were significantly increased after the 15-minute training session. Although the magnitude of the gain on the non-adapting side was 70% smaller. If a retinal image error signal is present in both directions of head rotations, then the gain on each side will be in accordance with the corresponding error. However, if the error signal is present in only one of the two directions, then the gain to both sides will be adapted on that singular error, but with greater adaptation on the side with the error signal. We can see in this patient with unilateral vestibular hyperfunction, the gain increased from 0.79 to 1.10, an increase of about 40%. In this same patient, the graphic is not on this slide, the contralational non-adaptating gain went from 0.90 pre-adaptation to 0.85 post-adaptation, about a 5% increase. That was not significant. What about these other concepts? The study published by McFoot and Coles in 2018 showed that optimal BOR training could be performed with active head impulses with similar velocity profile to passive head impulses, which eliminates the need for equipment or human assistance to deliver passive head rotation as part of vestibular rehabilitation. These findings support a strong recommendation from a recent Cochrane meta-analysis that conclude the gait stability exercises using active head rotation are an important part of vestibular rehabilitations. A recent study also showed the postural control is improved by active head rotation training. Sinusoidal versus impulse. This is another concept to keep in mind in order to understand the future direction of BOR training. This study also showed that there can be incremental BOR gain adaptation in semi-darkness. It suggests that contrast is an important factor for adaptations, which has implications for rehabilitation programs. BOR gain training with a bright target, such as a laser pointer DAT, can be done in a room with moderate light. That means light between 0.5 or 1 lux is the typical level of the light in a room with the curtains closed and the light turned off. In this slide, we can see 4 pictures of the stabilized version 3. And the author shared this video on YouTube. In this video, we can see the technology of this version of the Stabilize. We see the patient sitting in a chair and putting on the headband and then adjusting the setting on the screen . And finally, he adjusts the laser. You can see the different components of this tool. Laser, initial sensor, wonderful, beautiful. This is an example of the active BOR training to enhance right BOR gain. In this video, we can see that the left gain is always 1 and right gain increase from 0.5 to 1.5 at the end. Observe how the laser dot moved to the opposite direction. "15 minutes later, the right gain is 1.5. Now, at the end of this exercise, it's easier to see how the laser dot moved to the opposite direction. This is the Stabilize Plus, a hybrid system that combines video oculographic glasses and the Stabilize. So, with this system, it will be possible to do evaluation and treatment. We published a case report about unilateral head impulse training in uncompensated vestibular hyperfunction. The patient reported that the blurred vision only improved after completing a rehabilitation program using fast head impulse rotation towards the affected side for 5 consecutive days. Based on persistent symptoms and lack of improvement with traditional vestibular rehabilitation, we decided to treat her using passive and predictive yaw head impulses towards the affected side only. This was done for 5 consecutive days. Video head impulse test was used to ensure that the velocity of impulse was adequate for stimulating her right horizontal canal in the fast movement range. When the patient did the head impulse exercises, she sat in front of a solid black circle with a diameter of 10 millimeters on a white background placed at 1 meter. Simulation of the affected semicircular canal was stimulated with 10 series of 15 passive head impulses done by the therapist, with 30 seconds of rest between each series. I put this video here, as you can see, is the POR time 1 viewing, but it is done with head impulses towards the lesional side. Would this become a way of doing unilateral training in our patients? Would it work? What do you think? I leave that up to you. Recently, Dr. Lacour and team investigated the recovery of DBA in 28 unilateral vestibular hyperfunction patients whose unilateral deficit was determined by clinical history and video head impulse tests. The data provide the first demonstration in unilateral vestibular hyperfunction patients that IRI is better for improving DBA and passive ABOR gain. Gaze stabilization exercises could benefit from the plastic events occurring in the brain structures during a sensitive period or window of opportunity to generate optimal functional reorganizations. The whole population of unilateral vestibular hyperfunction patients was subdivided into 3 groups, depending on the time period between the onset of the acute vertigo crisis and beginning of vestibular rehabilitation. The vestibular rehabilitation exercises aimed at improving DBA were similar for the 3 groups of patients submitted to the DBA rehab protocol. So, the best phrases is IRI is better for dynamic visual acuity recovery. This is because the author observed that the patients who did gaze stabilization exercises sooner and no later recovered DBA thanks to the increase in ABOR gain in both active and passive head rotation, which is made possible by neural plasticity. Patients who began exercises later recovered DBA with the help of compensatory saccades, but this can only restore function in active head rotation. At this time, we don't have enough evidence to determine fifth principle with precision. Okay, we are close to the end of our class, and I would like to give you a message to take home. The first message is that DBA loss has a strong negative impact on the patient quality of life, so this justifies our intervention as health professionals. DBA testing while working on training is one of the few close to reality function measures of vestibular function in vertical plane. There is enough evidence that vestibular rehabilitation therapy enhances functional recovery, and it has been shown that gaze stabilization exercises improve dynamic visual acuity, or DBA. Also, we have seen unilateral and incremental VR gain adaptation is possible in humans, but randomized cultural studies are needed. Optimal VOR training could be performed with active head impulses. We should also remember that the visual contrast is an important factor in adaptation. And without doubt, early rehabilitation is much better for recovering dynamic visual acuity because your gain increases for both passive and active head rotation. Thank you for your attention. I hope this lecture helps you.